టైం మెయింటైన్ చేయాలి మన ఊరికి ప్రతిసారి అది 7 అయింది స్టార్ట్.
Sir, at what time my sharing is like?
Third speaker. You are the third speaker.
Okay, sir. Thank you.
We are live. We are live, sir.
Yeah. Very good evening to one and all, and welcome to Iadvl Telangana Dermanar 2. The Dermanar is a prestigious project of Iadvl Telangana 2021. So we are in the month of leprosy. So that's why this month we are going to sensitize more and more on the stigmatized disease, which needs more and more sensitization. Not only that, it is one of the great imitator in the field of medicine. So let us sensitize by ourselves. And the main concept of this Dermanar is to sensitize and update by ourselves from among the senior dermatologists from the state and from all over India. And the second thing is to sensitize more and more on the younger generation of the PGs. And third, we are in the awareness programs. So that's why we are in the awareness programs of the team Iadvl, that is a fight the topical steroid misuse, mainly for healthy skin, healthy body and healthy child. So with this and today's master of ceremony, I welcome Dr. V. Geeta. She is associate professor in Government Medical College, Siddipet, and vice president of Iadvl Telangana 2021. Now I welcome Dr. Geeta. Over to Dr. Geeta. It's your turn.
Thank you, Dr. Bhumish. Yeah, my video got stopped.
Geeta, first you. Okay, yeah.
Okay. So thank you. Once again, a warm welcome to one and all to our Dermanar 2. Starting with the welcome address by Dr. D.B.N. Murthy, Iadvl TS 2021 President. May I request Dr. D.B.N. Murthy, sir, to address the consultants, pages, and all the delegates.
Good evening.
D.B.N.
Yeah, good evening and welcome to all the members of the TS Iadvl and all over the country to this Iadvl Telangana 2021 Dermanar 2 initiative. Leprosy and syphilis, HIV, COVID-19 are challenging infections. And till now, we have not succeeded in eradicating them. Anyone who knows leprosy and syphilis, well, the physicians say that they know the general medicine well. There is always something to learn about leprosy even today. Today, the first speaker, Dr. Sujay Kumar Sunita, is a dedicated leprologist whose understanding about the etiopathogenesis of leprosy will be shared with everyone. The second speaker, Dr. Abhishek Bharadwaj, is an experienced and well-informed professor from Jodhpur. He is going to discuss about the differential diagnosis and differential diagnosis of leprosy. I request everyone to participate in the entire program and enrich their knowledge. Thanks to TSA Iadvl for giving me this opportunity. Now, Dr. Geeta, take forward this program. Thank you.
Thank you, sir. Thank you, Murthy, sir, for your welcoming address. Now, leprosy, a great imitator. So today evening, we have two eminent speakers who are delivering their speech on the above topic. So the first speaker, may I invite Dr. Sujay Kumar Sunita to enlighten us on the Etiopathogenesis of Leprosy. Sir is Director for Institute for Specialized Services in Leprosy, R&D Nirikshana ACAT Hyderabad, and coordinator of SIG Leprosy, has 35 years experience in leprosy and 70 publications. And our second speaker is Dr. Abhishek Bharadwaj. Sir is additional professor and HOD Department of Dermatology, Venerology and Leprology, AIMS, Jodhpur, and reviewer in dermatological therapy of various journals, including Iadvl and ANANS. Thank you, sir. Sir, may I request or Sujina sir to start his lecture.
Good evening to every one of you, and thank you so much for this opportunity to speak to you this evening on the etiopathogenesis of leprosy. I just want to make sure I'm heard. Can you hear me, please? Dr. Bhumesh?
Yes, sir. Yes, sir.
Okay. And I want to thank Dr. Bhumesh who invited me, and I want to thank the entire Iadvl Telangana team for inviting me to speak on this topic. And like Dr. Bhumesh mentioned, we are in the season where we remember the father of our nation, Mahatma Gandhi, and his passion and interest in leprosy. And so we honor him during this season. A few words of introduction. Leprosy is a chronic infectious disease caused by Mycobacterium leprae. And excuse me, I'll just is there a bar coming across the screens for you?
No bar, sir. It's a clear.
It's clear. Okay, fine. So it's a chronic infectious disease caused by Mycobacterium leprae, which is a gram-positive acid-fast organism. And what is very important is that it has a tough waxy coat that makes it difficult for antibiotics to penetrate. And it's an intracellular pathogen, and the human is said to be the only host for M. leprae. It takes almost 12 to 14 days for one organism to multiply to become two, so very slow generation time. One of the handicaps about knowledge about M. leprae is that it is not grown in artificial media, and therefore little is known about its biochemical characteristics and its growth pattern. In animals, it grows in the armadillos and in the footpad of mice. Leprosy is not a highly infectious disease, but it spreads by droplet infection from one person to another through close and frequent contacts with untreated infected persons. So it usually is an untreated patient or a patient who is unaware that he has leprosy, and when they cough and they sneeze, the droplets are expelled and it's inhaled, and frequent and close contact is what is propagated this disease. It is also known to spread through breaks in the skin, and we have reports of leprosy in tattoos. And later we'll see also Dr. Kanolkar's theory about M. leprae spreading through breaks in the skin. There are other factors that are related: poor housing, which involves overcrowding, breathing the same air, poor ventilation, poor sanitation, and more recently, genetic susceptibility to the disease. Looking at the spread of the disease, you find that it's supposed to be eliminated from the world in 2000 at that defined level of elimination of less than 1 per 10,000. It was just an epidemiological description, definition, but in reality, the WHO still receives reports from over 120 countries where leprosy is still present, and over 200,000 cases even after the so-called elimination, about 200,000 cases each year from the world. And interestingly, India contributes over 50% of the cases. At one particular point, it was almost 60% of the cases from India. So I'm going to deal with it in three segments. One is the etiopathogenesis of leprosy per se and of reactions. And if we have time, on the etiopathogenesis of nerve damage. Coming now to the leprosy itself. Like I said earlier, it's an intracellular pathogen, mainly parasitizing macrophages and Schwann cells, macrophages in the skin and Schwann cells in the nerve. The route of entry is the nasal mucosa. There was work in armadillos where they observed that um, when they were in the nasal mucosa, when there were thorns, they found granuloma around the thorns where the M. leprae had penetrated. And so there was that observation. There was also some work which I was involved in on PNL, where we found a significant number of patients had granulomas in the nose when you biopsied the anterior part of the inferior turbinate bone. We found granulomas and even M. leprae in the nasal mucosa. And then it enters the bloodstream and then localizes in the nerve. Khanolkar, very early in the 60s, propounded that M. leprae can also enter naked nerve endings in the skin and then enter the nerve and swim like a fish against the stream and then localize in the larger trunk and cutaneous nerves. So that was Khanolkar's theory about the route of entry as being skin. So the site of primary involvement is the skin versus primary involvement of the nerve. So we see both views. If you look at how exactly M. leprae attaches itself, how does it have a predilection for the nerve? We find that on the myelin membrane, there are glue-like proteins. And these glue-like proteins, the M. leprae adheres to these glue-like proteins, and that's how M. leprae is taken into the Schwann cell cytoplasm. So we find different molecules, alpha dystroglycan, myelin P0. I have worked on myelin P0, looking at amputated nerves and isolating the myelin and the protein, which was a 24 kilodalton protein, which actually attaches itself to M. leprae and then pulls it inside the cell. Laminin is the other protein implicated. Now, if you look at the immunopathogenesis, CMI, cell-mediated immunity, plays a key role in leprosy infection. Macrophages and Schwann cells release of M. leprae antigens. When these M. leprae break down, M. leprae antigens are released, and these are presented by macrophages to the T lymphocytes. And there is activation of T lymphocytes, recruitment of macrophages and lymphocytes. And then you have helper T cells as well as killer T cells, that all of which make up the inflammatory granuloma, and the release of pro-inflammatory and regulatory cytokines and chemokines, all of which contribute to the actual pathology and the pathogenesis of the disease. Based on the host immunity, we see the spectrum, which you all are familiar with. It's a clinical as well as an immunological spectrum, with on one side tuberculoid disease with a high CMI and a low antibody level. On the other end of the spectrum, a low CMI and a high antibody load. Lying all alone are two other entities. One is indeterminate leprosy and also pure neural leprosy. So these are two other entities that are apart from this spectrum, and we'll look at them in context of pathogenesis. When you come to indeterminate leprosy, where you find this lesion, which is a vague lesion, here you see very non-specific lymphocytic infiltrate that are centered around dermal nerve twigs or skin adnexal structures. But there is no differentiation into either epithelioid cells to suggest that it is on the tuberculoid lesion, or macrophages to suggest that it is lepromatous. So this is the kind of non-specific kind of infiltrate you would see, where immunologically the lesion is not determined whether it would move towards the tuberculoid spectrum or it would move towards the lepromatous spectrum. But you see a few lymphocytes around the nerve and around the blood vessels. You might find occasional M. leprae inside the nerve twig. So this is the indeterminate um, pathology, where you would also see mild inflammation. Tuberculoid leprosy is a more determined form of leprosy, where there is a Th1, a T helper 1 type of response. Now we'll see later when we look at lepromatous leprosy, there is a Th2 type of immune response. But here it's a Th1 type of immune response where there is more of gamma interferon production. The bacilli are limited, lesions are limited, whereas the damage to the nerves is much higher, because you see a delayed type hypersensitivity reaction that damages the nerve. Histologically, you find that there is aggressive granulomas which are impinging the basal layers of the epidermis, overlying epidermis. You find a giant cell response also is very typical in tuberculoid leprosy. But giant cells indicating that these are macrophages that have actually succeeded in bringing down the number of bacilli, and so that's successful macrophages, I would think, or histiocytes, epithelioid cells that actually are seen here morphologically as giant cells. Borderline tuberculoid, and then mid-borderline and borderline lepromatous are another part of the spectrum that is very unstable immunologically and move upwards or downwards in the spectrum based on the cell-mediated immunity. Now, when we come to borderline lepromatous, you see there is a Th2, T helper 2 type of response, and there is more production of TNF alpha and other cytokines and chemokines. There is a cellular unresponsiveness to M. leprae. Whereas we saw on the tuberculoid size, there is a delayed type hypersensitivity to M. leprae, but here there is an unresponsiveness, an anergy to M. leprae. And bacilli proliferate, there is no limit to the lesions, there's a very poor lymphocytic response, and damage to nerves is less and slower. So this is the borderline lepromatous side of the spectrum, where there is proliferation of bacilli and there is extensive involvement of the skin. And you see foam cells are also part of the lepromatous process. We also find that the antibody levels are high. You will see plasma cells, plenty of plasma cells in the lesion, indicating that these are activated B lymphocytes that are producing antibodies in the lepromatous side of the spectrum. You see low CMI and very high humoral immunity on the lepromatous side of the spectrum. So That was about the main spectrum, tuberculoid to lepromatous and also indeterminate. But like I said, PNL stands alone. Here again, how does PNL present? You find pure neural leprosy, where if the skin smears are negative and the involvement is mainly in the nerves. And what is the pathogenesis of PNL? It seems to be different from the others. The entry is through the nasal mucosa, entry into venous sinuses. The M. leprae gets into the venous sinuses, carried by the bloodstream to trunk and cutaneous nerves rather than to the skin. And then you get pure neural manifestation and ultimately treatment and resolution or extension to the skin. When you look at a lot of these skin biopsies, you find the granulomas or inflammation or M. leprae are in the deeper layers and unable to affect the stratum basalis, and therefore you don't get hypopigmented lesions. But subsequently, sometimes granulomas can rise in the dermis to affect the overlying epidermis, and you might produce visible skin lesions. So this is the whole spectrum of indeterminate leprosy, TT to LL, and PNL. So that is a bit on the pathogenesis of the disease. Just a word on etiopathogenesis of reactions. Reactions are very important because they are known to cause damage to nerves and to tissues, and therefore reactions have high interest. They are episodes of acute inflammation during the normal course of a disease. And I think all of you know there are type 1 or reversal reactions and type 2 or ENL reactions. The type 1 reaction, it can be upgrading or downgrading. Upgrading when there is an upregulation of Th1 response, and downregulating of Th1 response will cause a downgrading reaction and movement from the lepromatous to from the tuberculoid to the lepromatous end of the spectrum. The time of occurrence can be first 6 months of treatment. Late reactions can occur. Post RFT reactions can occur. Repeated reactions can occur. And the natural course of a type 1 reaction is spread not over weeks, but over months. And nerve damage is severe. So therefore, type 1 reactions have to be should be looked at quite seriously and dealt with adequately. There are many precipitating factors, and there are risk factors. Positive skin smears, MB patients are more at risk. Extensive skin and nerve involvement are more at risk. Pre-existing deformity, increasing age. So there are different precipitating factors and risk factors. And like I said, it's a DTH type of reaction. If you look at it in the context of Jelen-Coombs reaction, it is a type 4 hypersensitivity reaction. There's a breakdown of M. leprae, release of bacterial antigen processing and presentation to macrophages, recruitment of T cells, activation of T cells, release of cytokines and chemokines, inflammation and edema. And it is also postulated that humoral immunity also can play a role in type 1 reaction. So inflammation, edema is prominent. One of the things that is prominent is edema that causes edema of the lesions as well as in the nerve. Edema can result in axonal destruction and demyelination. Type 2 reactions is immune mediated, and it's seen in LL and BL leprosy. It's seen in high BI patients, occurs in up to 50% of patients, some parts of the world, and mostly occurs in the first year of MDT, but it does tend to occur even in the second year after that 12-month FDT treatment. Pathogenesis of ENL, it is different from type 1 reaction. key role of humoral immunity and corresponds to Gell and Coombs type 3 uh, uh, reaction or Arthur's phenomenon, and release of M. leprae antigens and antigen antibody complex formation binding to the walls of blood vessels, activation of the whole complement cascade, inflammation, cells, cytokines, chemokines, and organ and tissue involvement, constitutional symptoms, nerve damage, and we see that CMI, just like in type 1 reactions, humoral immunity plays a role. There are some studies to show that even in ENL, not only humoral immunity, but CMI also can be involved in, uh, in the pathogenesis. So key molecules are TNF alpha, TGF beta, and inducible nitric oxide synthase. So you find three compartments in which they can be involved: the nerve, the blood, as well as in the skin. And you'll see later that the skin changes occur much later than what happens in the nerve and the blood vessels in the bloodstream. Now, coming lastly to the etiopathogenous nerve damage, very briefly, there are direct factors to the damage of nerves. One is inflammation-mediated nerve damage. The nerve is inflamed, and there are plenty of inflammatory cells, as well as edema. All these damaging the nerve. The other could be pathogen-related nerve damage. That is, M. leprae itself, as it enters the Schwann cell, it alters the internal milieu of the Schwann cell and destroys the Schwann cell. As a result, the nerve undergoes demyelination. And demyelination is one of the first steps in the damage to peripheral nerves. Then would occur axonal damage. Thirdly, immune-mediated nerve damage. Because of release of M. leprae antigens, as well as release of Schwann cell proteins into the bloodstream, antibodies are produced in the bloodstream, and therefore a few antibodies that are directed against the myelin can cause immune mediated nerve damage to the individual. So all of these contribute to nerve damage in leprosy. The other factors are the mechanical factors of the fibro-osseous tunnel and trauma and environmental factors, and genetic factors also could contribute to the nerve damage. So invasion of M. leprae, demyelination, inflammation, granulomas and necrosis, axonal damage. So these are different ways in which nerves get damaged. Sometimes whole nerve gets damaged, leaving hardly any normal fascicles. In conclusion, much is known about the pathogenesis of, is still to be known on the pathogenesis of leprosy. A lot is still unknown. Early events of M. leprae, how does M. leprae enter? How does it parasitize nerves and the skin? Still a lot to be studied. The role of antibodies in controlling infection. Why is it that lepromatous patients have got so much antibodies, but yet unable to control the infection? Role of CMI in ENL, steroid non-responders. Why do some people respond to steroids and don't? Sometimes these reactions do not respond to steroids. Preventing reaction and nerve damage is something that we need to still study, and the pathogenesis of reaction and nerve damage. Role of immunization, what can a vaccine like MIP or BCG do to prevent leprosy, to prevent nerve damage? There is a need for continued research. And I had said a few take-home messages, and I think these will be circulated um, by Dr. Bhumesh and the team. And so these are some of the things I have added to my presentation this evening. Thank you very much for your patient hearing, and thank you all for this opportunity to speak on the pathogenesis of leprosy. Thank you, sir.
Thank you, Sujay sir, for the lucid and informative session. It is very much useful, not only for the PG sir, for all the consultants and our practicing leprologists. Once again, I'm thanking you. Now, may I invite our second speaker, who is going to enlighten us on the diagnosis as well as the differential diagnosis of leprosy. I'm inviting Dr. Abhishek Bharadwaj sir. Dr. Abhishek Bharadwaj sir.
Yes, ma'am. I think, yeah. Can everybody hear me?
Yes, sir.
Yeah. At the outset, a very good evening to all my seniors, colleagues, and friends at Iadvl Telangana. And I thank Dr. Bhumesh and the Telangana team to have called me to talk about leprosy. Briefly, I will be talking about it in certain headings. The topic given to me was diagnosis and the differential diagnosis of leprosy. I think my screen is visible to all.
Yes, sir.
Thank you. Sujay sir is an elite speaker as far as leprosy goes, and I am nowhere near his experience in the disease. But I think I must share with my friends the fact that when I joined dermatology, and my guide asked me what topic would you like to work on, I had this emotional connect with leprosy because we all understand that Mahatma Gandhi was closely attached with the disease, and the fact that I think I recollect a comment where he said something very beautiful, which we all aspire to, that it's no greatness in treating or opening hospitals. I would be the most happy when I come to close a leprosy treating facility. I hope that day is somewhere in the future, and I have been already liberally introduced to all of you. And as I told before, Dr. Bhumesh has given me the brief to talk about diagnosis and differential diagnosis of leprosy, or as we all know it as Hansen's disease. Well, Sir William Osler is widely understood to be the father of modern medicine. And despite the fact that we dermatologists tend to examine and listen a lot less, I think it's appropriate to remind ourselves time and again that we should continue to listen to our patients. They might very well be giving us marvelous insights, and definitely, as my PGs or my PG friends hearing this webinar would, I would definitely like to underline it that it's always a good idea to talk to the patient, not only to build rapport, but to understand the nuances of this disease, because this disease is a very unpredictable and very minute and nuanced sign throwing disease. My job was made again very easy by Sujay sir when he talked about where India stands today as far as leprosy goes. The picture is not at all rosy, as you can make out by this image that I have taken from WHO. This is in fact dated no less than 6 years. And the bottom line is that we are in the top 3 nations contributing the new leprosy cases. And it is far from over. The government did declare elimination way back in 2005, but the fact remains that there are certain pockets where this figure is still in the distant future. So we need to keep our eyes open. We need to study so that we don't miss the art of catching a case of leprosy. I try to make it a simple, straightforward teaching sort of a presentation, and therefore I would like my PG friends to understand that when to suspect leprosy whenever you see a case. But most of the cases, if you ask in detail, do talk of the fact that there was some numbness or tingling of the hands and feet. If at all the patient has presented you with a skin lesion which is hyperpigmented or otherwise, if you ask these patients whether or not did you suffer from something called as insect crawling over the limbs after prolonged sitting or prolonged suspension of the limbs, you will find most of them agreeing to it. The other important symptom that you look for, or sign that you look for, is the weakness of the eyelid and the hands and the feet, especially distally in the fingers. The other important point of suspicion of leprosy is painful or tender nerves, but likely to be more during the reactional episodes than otherwise. An interesting sensation to look for or ask for is the burning sensation in the skin. Because it being a neuropathy, all sorts of neuropathic symptoms can accompany leprosy. The other interesting thing that you can, as a dermatologist, can straight away look and discern or identify is the presence of painful papules or nodules over the exposed parts, especially the face and the earlobes. Another way of presentation, which my PG friends would understand, are the painful wound or burns on the hands or feet. And I distinctly recollect while sitting in the OPD, since I did it in an area which was high incidence of leprosy and where mustard oil was used a lot, patient used to come and let us know that, okay, it seems that a rat has bitten us, and that was actually a sum total response of a liberal application of an edible oil like the mustard oil, and the fact that the biting of the vermin was not noticed by the patient. Loss of eyebrows and or eyelashes, well, this is something which thankfully in the past few years and decades, since it is seen only in lepromatous cases or cases who have not been diagnosed appropriately at the appropriate point of time, we see a lot less of this madarosis. An interesting symptom that I would like to highlight is something which I was taught during my post-graduation, that if a patient in a high endemic zone talks of hyperesthesia and is not hysterical, do keep a high index of leprosy itself, because in the course of involvement of the nerve, as Sujay sir was pointing out, the inflammation and the pressure on the neuronal endings ends up producing varied symptoms. Varied symptoms like, as I said before, burning, maybe as if ants are crawling, as if there is a lack of movement or a weakness, all of them attributable to the pressure effect of the influx of the bacteria or the pressure effect induced by inflammation itself. I will take a minute to underline what WHO has been doing. Although it has done a stellar job, we all understand WHO controls the treatment of leprosy in the part that right throughout the world, and has indeed done a stellar job of at least arriving to a state where we can use the word elimination. It has changed a few benchmarks and has introduced a few points which are a bit different from what we used to study some time back. My PG friends would understand that we are looking for a definite loss of sensation in a pale or reddish skin, and this is something which is the first thing that you generally look for as a cardinal sign. Or you look for a thickened or an enlarged peripheral nerve trunk with loss of sensation. This is a lifesaver of a cardinal sign, especially in India, where the Ridley-Jopling entity doesn't entertain the entity of pure neuritic leprosy, where you won't find a skin patch. But having this cardinal sign of having thickened or enlarged peripheral nerve with a loss of sensation associated with it, it saves us in diagnosing PNL. Then there is this third cardinal sign of the presence of acid-fast bacilli in a slit skin smear. Mind you, WHO believes, and we all should understand, that either of all these three is good enough to diagnose leprosy. Well, how do these skin lesions look in leprosy? Again, a bit elementary thing is hyperpigmented, and something which amazes me, coppery red. Actually, coppery red is more of a reflection in people with pigment, where the erythematous lesion mixed with the brown color does give the hue of copper. The lesions can be single, they can be multiple, as was told by Sujay sir also. Single in the case of indeterminate leprosy is a very tricky diagnosis to make. I will concede that. Ideally, it should be associated with some or the other sensory loss. But again, the caveat is, if the lesion is on the face, a solitary lesion on the face, then again, face being richly supplied by nerves is not the ideal site where sensation testing itself should rule leprosy out. But mind you, if you are discerning enough, and my teachers used to point out that just because the lesion lies on the face, it should not give you the permission of not doing a sensory test. Depending upon the duration of that particular skin lesion, it might very well happen that you can elicit some sensory deficit. Interestingly, there is this statistical fact that if you are looking for the loss of the touch sensation alone, the sensitivity of utilizing it as a tool for diagnosing leprosy is as high as 93% in paucibacillary disease. But the unfortunate part is that in the what I may say more damaging multibacillary disease, the symptoms sensitivity falls to 50%. Morphology, as we all understand by the marvelous talk given by Sujay sir, is dependent upon the immunity of the individual and varies from the spectrum from one corner to the other. But then we should definitely look for things which takes away leprosy from us. I have a distinct recollection of sitting in my spotter viva, where my examiners, there was this history of looking at a hypopigmented lesion, and since I did my PG in an endemic zone, I was asked, what is the one question that you would like to ask to rule out leprosy? Well, two distinctly came to our mind, and the one used to be, if permitted in a spotter, what is the duration of the illness? Because Hansen's or leprosy is by definition a chronic disease. The other is, the Hansen's lesions generally don't age. But you don't suspect leprosy when the patient clearly says that it's a birthmark. Neither, as I told you before, you suspect leprosy when the patient is distinctly talking about itching as a presenting symptom. Mind you, we are looking for asymptomatic lesions. Color-wise, if it is depigmented, I am stressing white as in depigmentation and not hypopigmentation, or it is black, clearly black, or dark red, it is very unlikely to be leprosy. If I rule out LNL, where the appearance can be sudden, most of these skin lesions which appear or disappear suddenly don't stand as leprosy. I will take some time to talk about a few tips which might help my PG audience for history taking during a case of leprosy. The first point, as in all cases, should be, what is the duration? While doing the duration, asking about the history, it's always a very good idea to take a rough count of the lesion and then ask the patient about the lesional chronology. By chronology, I mean that the patient should be taken into confidence, and he must be asked to communicate which lesion appeared first and which lesion appeared recent most. Why I say so is that more likely or not, you are going to diagnose something in the borderline spectrum, and the borderline spectrum is not stable. There is a lot of downgrading, and if you are discerning enough and if you give time enough, you might be able to make out as to how lesions are changing from the start and how they have progressed and how they are reaching to the present size. The other point that I would like to give as a tip for history taking is to be careful about covered areas. This is during routine OPD, and I am 100% sure that nobody among you will hazard leaving the covered area during an examination, but it's another good idea while looking at cases in a busy OPD to take the patient into confidence and take for a full body screening, especially the buttocks and the covered areas in the females, because they can have lesions which can be ignored. Sorry, excuse me. The point about chronology is important because more often than not, the natural history of the disease states that it will downgrade. If you are not talking about the indeterminate leprosy evolving into the polar spectrum, it's likely to be in the borderline, and it will more likely downgrade. It will begin with a well-defined larger lesion and will probably will be shifting towards ill-defined smaller lesions. By that means you can very well point out clinically as to where exactly in the spectrum does the patient lie. Neural symptoms, as I've been talking about, are important, and I have referred to it before that they can range from tingling. And one question which we used to definitely ask is whether the banging of your elbow or the banging of your knee to any structure around, maybe a wall or maybe an accidental banging into a chair, does it lead to a sensation as if you've got a current shock? And people in endemic region would identify, although this description doesn't make its way into textbook, but it is right there in a large number of patients. Some patients do complain that there was some sort of insect crawling before numbness itself set in. Another important point to note is, and that I have learned through my own, you may say, an attempt to quickly come to a diagnosis is that it's a peripheral neuropathy. And it is always a good idea to, once that you have seen the covered parts, to focus especially over elbow downwards and knee, elbow and distally, and knee and distally. Because these are the cooler regions. These are the regions where you can actually find, you are likely to have more findings than proximal to it. And I'm not underlining the fact that you have to ignore other areas. I'm merely saying you should focus on the fact that it is a distal polyneuropathy, and you are more likely to see things distally than centrally. Nerve function impairment symptoms are definite to set in leprosy. They comprise of either hypoesthesia or anesthesia. We understand that if the patient sits in the tuberculoid pole, he's likely to have a wide-ranging loss of sensations. We say patients towards the lepromatous end of the borderline or the lepromatous pole itself, where the sensation loss may not be overwhelming. An interesting thing that I think can be noted and is not very pronounced in textbook is that there is a lack of sweating and a loss of hair that is there in red ledge opening. We all understand. But in the class of patients who come to us, and most of them being of the working class, an interesting symptom, if you ask them, is of a compensatory hyperhidrosis, that after a day's job in the sun, their undergarments, the banyan, if I may say so, is drenched because that part is having a compensatory excess of sweat, while comparing with limbs, where the neuropathy, autonomic neuropathy, has ensured that the sweating has gone away. Ulcers, active ulcers, or scars of previous ulcers are important. They should be looked for, especially in the distal parts of the body. Weakness, with or without deformities, are equally important. Asking patients whether your slipper slips off, asking patients whether your grip is weakening are important questions during history taking in a case of leprosy. Face is something, I would admit that somebody in a hurry might ignore. But mind you, with face, we are talking about eyes. Eyes are very important as far as leprosy goes. You may find publications where they mention that eye may be the brunt of the disease in as many as 70% of the cases, and a red eye is not to be missed for. So examination of the eye doesn't stop at madarosis. It does extend to the region around the conjunctiva, the region around the cornea, and the conjunctiva, and definitely the lid margins. The nasal stuffiness and epistaxis, thankfully, considering that we are in the elimination phase, this symptom is seen a lot less. But I will add a caveat. The fact still remains that more than 60% of cases that are being diagnosed, interestingly, are multibacillary, which we expect in elimination. There might be an odd case which has missed every barrier at the PHC or the UHC and has reached you after years of the disease, misdiagnosed under various headings, and may talk of nasal stiffness or epistaxis itself, which are symptoms of the lepromatous pole. Systemic symptoms. They hold importance during reactions. They hold subtle importance during the progression of the disease from the during the downgrading, that is for sure. But more likely, systemic symptoms like fever, joint pain, and all sorts of itis, whether it is arthritis or conjunctivitis or iritis or iridocyclitis or osteitis or orchitis, are part and parcel more of type 2 lepra reaction. So systemic symptoms, please do not rule out. Personal history and family history are important. I will underline this with a slide later on. Personal history, because there are cases, because of the wide spread of the program, who come after taking a course of treatment. Whether appropriate or inappropriate is a judgment which can be taken later on. And family history is important because the source of the case could very well be an index case in the family, maybe the father or the mother, and or the other way around, that the patient itself may be infecting a few other patients in the family. This is important now. Trying to ignore this actually tends to diminish the quality of the program. These are important histories which should not be ruled out. Past treatment is, again, as I told you before, equally important. Whether the patient got an appropriate MDT, whether the duration was appropriate, whether it was taken adequately, all of this holds importance. Now, this is the case. We at AIIMS Jodhpur run a satellite clinic with the tribal centers in South Rajasthan. And my colleagues there sent me this photograph. And as we all can make out the callus and probably the neuropathic ulcer part in this case. And the first thing that should come to the mind of a dermatologist is a peripheral neuropathy like leprosy. When the patient, this is the photo I got prior to the talk with the patient, and after the talk, during the course of the talk, I asked whether you have taken a treatment through a government facility which comprises of months treatment, maybe red colored for some time, and the answer, Pat came, the answer yes. A similar thing can be seen in diabetes, I agree, but from the dermatological point of view, looking at such a case in an endemic zone and not asking about leprosy is criminal. I will continue with the talk by showing a few slides about how varied the various cutaneous lesions can be. So just as I made my task easier, I will run through. And the horror of everything is this, the indeterminate leprosy part. And we at SIG Leprosy at times discuss such cases as to what appropriate thing, what appropriate treatment can be offered, how to proceed. But you can very well find patients who come with a single ill-defined hyperpigmented macule, maybe a plaque on the face. This is more likely to be a picture of indeterminate leprosy. Why is this second picture important? Well, very unlike the first face, this face you can clearly make out is a lot angrier, with the margin being a lot more prominent, with a pseudopode being thrown out, maybe converting into a satellite lesion, and very likely to be suffering from a type 1 lepra reaction besides tuberculoid leprosy. This dry-looking hypopigmented lesion, well, you can very well see that there are 4 lesions in these photographs. And you can, although it's the back of the patient, and it's very, very unlikely that the patient is going to give you a very good chronology history, but you can make out that if you begin from the buttock upwards, you can clearly see a TT colored, a TT patch with a lot of dryness and loss of hair. But as you move upwards, you can see what we love to call as active lesions of leprosy, where you can see the shine and you can see the pseudopods and the satellite lesions. Therefore, the importance if the patient has seen his back or some family member has seen his back as to which lesion has appeared earlier and which has come later. This will help you pinpoint clinically whether the patient is sitting in the borderline tuberculoid diagnosis or thereafter. Then come the annular lesions. We all understand the inverted saucer. There is a little confusion which I would like to highlight. Well, there is something called as an annular lesion, as described in the legend below. Now, the annular lesion has two margins, an inner margin which is very clear. I hope the cursor is clear, and an outer margin which is equally distinct. That is what is annular. When we call about inverted saucer appearance, we are talking more of a lesion like this, where you can partly see the well-defined inner margin in the upper part of the skin lesion, and you can see that there is a sense of non-defining in the lower part of the skin lesion. It is getting merged with a few. So you can clearly see that this patient is downgrading. I have used the textbook pictures to make my understanding clear. Infiltrated lesions of borderline leprosy, well, as I was talking about before, as the lesions chronologically progress, they are likely to become more granulomatous or shiny or red and lesser in size. Although in this case, I admit, I will be surprised by the clear, distinct margin of the lesions, because in lepromatous pole or borderline lepromatous and thereafter, the margins are not likely to become prominent. These are the infiltrated skin lesions over the face with multiple overlying nodules, something which may be called as early onset of leonine facies in a case of lepromatous. Another morphological variation is the presence of what we call as grape-like solitary or a cluster of succulent-looking papules or nodules of histoid leprosy. Mind you, these should not be a diagnostic dilemma purely because these succulent-looking, you can see as if a grape is losing its a grape left for some time loses its tensile strength, and you can see the margins as if it is losing its fluid. This is what is the classical appearance of histoid leprosy is, and obviously the fact that it sits on an underlying normal skin, unlike the infiltrated skin that might be seen in a different case of lepromatous pole. Nerve involvement is an important finding in leprosy, and in a hurry, I must not say as a teacher, pardon somebody who looks only at the ulnar and the lateral popliteal or the common peroneal nerve and move forward. Mind you, these are the two most common nerve trunks, but these are not the only nerve trunks. And if you look at it from even the working classification, you have to seek all major peripheral nerve trunks, because if your count increases from 1 to 2, mind you, your treatment protocol changes. I will be talking shortly about why we tend to miss nerves while examining. One being the pressure of the OPD, I agree. The second being poor technique, something which we focus a lot less. And therefore, it's a great idea at all centers to have a leprosy clinic where you have back-to-back cases where you can see the entire spectrum of the feeding of how a nerve is clinically felt throughout the spectrum of leprosy. False positives, well, the theory books do underline the fact that if you have manual laborers, you can have thick nerves. But I would still say that if you notice their consistency, you will be able to make out with experience that these are not the disease nerves of leprosy that we are looking at. Amyloidosis, neurofibromatosis, HMSN are much, much rare in dermatological references than leprosy. The other thing is, okay, that during the inspection part, you missed something, but once that you have come across a thickened nerve, it clearly means that the pressure would have led to something down the drain, maybe sensory loss or motor weakness. You should make an extra attempt if you have found a nerve where you didn't see a patch, whether this area of supply has a distinct sensory loss or not. This is a textbook picture of the nerve abscess in the greater auricular nerve. Mind you, these are not seen that much anymore, and this picture is clearly dated, and I take it from the Jopling's handbooks, the recent edition, and the picture is dated. I agree again. And a very good tool under these circumstances is the modern tool of the ultrasound of such lesions. Slit skin smears are important. Once that you have seen the case and you're trying to diagnose leprosy, you have examined the nerves, you have to do, as a postgraduate, a slit skin smear, because it is a highly specific cardinal sign. It's an individual cardinal sign, and it is 100% specific. The sensitivity, unfortunately, is very operator dependent. We are looking for lymphatic fluid, and I have seen many people making the mistake of allowing blood to pass out and thereby decreasing yield. And I have seen, I will be loath to admit, but my microbiologist friends looking at the smears thereafter and commenting of a very, very high percentage, something which doesn't fit in with leprosy. But so the technique is not exactly demanding. All that it needs is practice. Mind you, slit skin smear gives you access to at least two informations: the bacterial load, which will help you classify disease, and the morphological index with the amount of killed bacteria, which will help you in due course of time to monitor treatment. Here, I would like to point out something which I missed mentioning in my slides before. There is this general tendency of all dermatologists to arrive at a conclusion of Ridley-Joplin and very conveniently write Hansen's disease or leprosy, borderline tuberculoid, purely on the clinical criteria. Mind you, when our Ridley-Joplin gave this criteria, they did include two other aspects which we conveniently overlook. One being the Lepromin test, unfortunately, which is very, very difficult to technically do and to get the material to do it. But the other part is the histopathology, which we should not forget, where seniors like people like Sujay sir, who have given a lifetime's work on how histopathology helps in diagnosing a case of leprosy. Mind you, all this sums up into a RJ or a Ridley-Joplin classification. Equipment and logistics for doing a smear preparation are not costly. The will and the time is something which we all should be looking forward to push. Readings may need more experience and expertise, but that will only come if we continue to do this. We should be talking about a few other presenting symptoms too. These are motor weakness alone, tenosynovitis over dorsa of hands or feet, at times representing reactional episodes, swelling of feet, nasal stuffiness I have talked before, epistaxis I have talked before, iridocyclitis has redness around the limbus as a manifestation of type 2 leper reaction, loss of eyebrows I have talked about, symptoms of reactions which are acute episodes during the course of otherwise a chronic illness. All of them are important attributes while looking at a case of leprosy, while trying to diagnose it. These are the findings. This is the general edema of hand and feet, which you see in a case of lepromatous leprosy and at times during reaction. The madarosis and the reduction in facial hair growth, probably secondary to orchitis over a long period of untreated, undiagnosed disease. And the lack of androgen, again, a prolonged period of undiagnosed disease, damage to the testes, poor secretion of androgen, thereafter gynecomastia. What about suspect cases of leprosy? These are cases which do not exactly fit in with the cardinal signs I talked about, and they do appear in the OPD. you have to rule out a few suitable diagnoses. Say, for example, Psoriasis alba in a case where I showed the face. And it won't be a bad idea once that you have eliminated the common differentials to counsel the patient about the possibility of leprosy. Mind you, I'm talking about the possibility and do not make the patient sit alarmed. Because offering the patient treatment which may last anywhere between 6 to 12 months purely on an incomplete cardinal sign is not appropriate. So a good idea would be to do a follow-up, maybe after 6 months, or if the symptoms are persisting or are downgrading, you can allow the patient to come earlier also. After giving a few diagnostic tips, I would like to give some examination tips to my PG friends. Well, as a practitioner, I prefer daylight because daylight does lets you know subtle lesions which you would otherwise miss in a routine OPD. Do take a look at pallor and edema of hand and feet and lymphadenopathic gynecomastia and the testicular consistency too. If it's a long case, mind you, if you don't put your hand to the testis, you might be missing an important finding. Proceed systematically from the head downwards, and you are less likely to miss a finding. Look for discoloration, swelling, or something which we quite often mention during the course of examination called as infiltration. Notice the characteristics of meaning the morphology, the margin, the hair, the shine, the scaling, all of them helps you in pinpointing the exact diagnosis. You look at the number, size, and distribution. You look at the definition, the shape, size, and the pseudopores, and the satellite lesion, as well as the hair distribution. Please do keep your magnifying lens, torch, scale, cotton wisp for sensory examination, a ballpoint pen. It's very useful in doing a sensory examination because we don't have the monofilaments everywhere, and test tubes for the thermal or the taking up of temperature, loss of temperature sensation. Nerve examination. Please don't be in a hurry. Nerve examination needs a lot of time. You're not only looking for palpability, you're talking of compressibility. You are trying to define the course, understanding the exact anatomy, looking at the consistency, and definitely looking at the face while doing so for eliciting tenderness. Well, there are no less than 6 nerves in the head and neck, 4 in the upper limb, 5 in the lower limb to be done while doing a complete nerve examination. You can't be spared not looking at each nerve as described in textbooks. The other point which I have seen most PGs doing a mistake is to poke and try to pick the nerve through the fingertips. Mind you, nerves are better palpated using the pulp of the finger and not the tip. Nerve examination, unfortunately, is subjective, and you can see a lot of variation might happen from PG to PG or PG to teacher or faculty to faculty. Don't be worried. Just make a good note of the finding, follow it up. Your finding might be fruitful sometime later. And again, if the nerve is thick, there is bound to be some function impairment. Look for the function impairment. Down below, it might be causing some loss of sensation or some weakness. Differential diagnosis is the other domain which has been given to me, and if I have time, I would like to go through each one of them. In an endemic country which contributes 60% of the cases of the caseload of the world, a case which is having a hypoaesthetic, hypopigmented skin lesion is more likely to be leprosy than anything else. But is it so simplistic? Well, the answer is no. As you can clearly see, that the differential diagnosis runs from entities which are pretty much more common, say Psoriasis alba, vitiligo, versicolor. But then it goes into domains which are little more endemic. A post-Kala-Azar dermal leishmaniasis. Leukoderma syphiliticum is not seen by me, so I won't suggest it as a very common diagnosis. Post-inflammatory hypopigmentation. Lichen sclerosis, morphia, progressive macular hypomelanosis, idiopathic guttate, hypomelanosis. Now, these are DBs on the basis of the hypopigmented macule spectrum. So they will look something like this. This is, as you can clearly make out, Psoriasis alba, but this can very well be indeterminate leprosy. do follow this patient up. Vitiligo, well, the well-demarcated, depigmented macule takes it away from leprosy. If in doubt, use a wood slab. That is all that is needed. Hyperpigmented lesions of healed psoriasis, well, again, as I told you before, high index of suspicion, endemic zone, it's a good idea to rule out leprosy. What if you get something of a papuloplaque? Well, as you can see, these many differentials are possible, right from granuloma annulare to a mycosis fungoides, granuloma, oh, it's a repeat, granuloma facial was the previous entity, I'm sorry, sarcoidosis, Edema annulare centrifugum, syphilis, lupus vulgaris, granuloma multiforme, follicular mycinosis, lymphocytoma cutis. Now, if you go back and just do another exercise, which I have not done, and look at individual incidences, you will note that in an endemic zone, leprosy is again much more common rather than looking for a lymphocytoma cutis. But I'm not again pointing out to the fact that you do an oversimplification. Do a sensation test. It may most often than not lead to your appropriate diagnosis. So this is a granuloma annulare. Some might mistake it for tuberculoid leprosy. Well, this is a mycosis fungoides. I don't think this can be mistaken, but yeah, these are textbook descriptions. Tinea, dime a dozen in today's OPD. The itching takes it away, the acuteness takes it away, but now it's no more acute, so therefore itching will take it away. If you're looking at it from the point of view of infiltration, again, there are 4 or 5 entities. Post-Kalazar dermal leishmaniasis, more in Bihar, Chhattisgarh, and Orissa than anywhere else. Sarcoidosis, much lesser incidence. Disseminated cutaneous leishmaniasis, well, again endemic to only a few zones. Rosacea, textbook, yes, but I don't think a PG should make a mistake of having a reddish, bilaterally symmetrical convexities of the face involved, and you end up diagnosing leprosy. And lipoid proteinosis, well, again, textbook, differential, yes, good for writing a short note on differential diagnosis of infiltration, but in a routine OPD, it's very unlikely to have the monenial blepharosis away from a lipoid proteinosis in a case of cancer. Now, these are a few photographs where, say, PKDL, somebody in Bihar will definitely identify this fact that, okay, this might be PKDL, but somebody like me sitting in Rajasthan, where visceral leishmaniasis is not leading to PKDL, we have a different form of cutaneous leishmaniasis. This should likely to be leprosy, although it's a low endemic zone. These are again a textbook picture, and this is not Hansen's, this is sarcoidosis. A simple slit skin smear will also help you rule out, because here a nodule on the earlobe would point out towards a lepromatous where sensation loss may not be present. If it presents early in disease, the nerve involvement may not be a very good clinical tool. A simple slit skin smear will help you rule out leprosy, and a biopsy will confirm sarcoidosis. Differential diagnosis of madarosis also exists. Well, hypothyroidism, alopecia areata, and cutaneous mycinosis are diagnosis of madarosis. But as you can see, these are piecemeal theoretical differentials of leprosy. The differential diagnosis of peripheral neuropathy with nerve thickening is again a long list, and the neurologists will be more interested, or the physicians will be interested, because diabetes is much more common. Although, as a dermatologist, I always get puzzled by the fact that how come diabetes mellitus will lead to a thickening in the nerve. The other differentials include neurofibromatosis, Refsum's disease, amyloidosis, acromegaly, HMSN type 1, and autosomal dominant hypertrophic neuropathy. Again, in endemic zone with accompanying skin lesion, which is having hypoesthesia, the diagnosis to beat still remains leprosy. This is my but. This is what I wanted to say, but with all those small points, that in an endemic zone with a high index of suspicion, maybe somewhere in Telangana where the incidence is still not less than 1 per 10,000, it's leprosy that you should rather be ruling out rather than anything else. Before talking of my references, I must commit that in tertiary centers, there are other tools available to rule out the differentials. These tools include ultrasonography, which again is not that limited to tertiary centers. That can very well be done by a dermatologist sitting in a private clinic where you have a nerve thickening. It can be sent for an ultrasound. The other tests that we can do are the nerve conduction tests, which are very helpful and are known to have a sensitivity to the tune of 88 to 90% in diagnosing leprosy. Then there are tools like the PGL1 antibody measurement or the PCR in leprosy, something which are more associated with centers with research capabilities. Well, references are primarily three now, I can say, but I have consulted a few more publications to make this presentation lucid enough for my listeners. And I thank again the branch and Dr. Bhumesh for giving me this opportunity to talk about leprosy and its differential diagnosis. I thank you all for the patient hearing.
Thank you, Abhishek sir, for the very much useful, valuable, and practical point of view. It's very, very useful session, sir. Thank you once again.
Thank you, ma'am.
Yeah. Now, may I invite our third speaker of today's evening, Dr. Mohan Lal, Associate Professor, DVL Department, Usmania Medical College. He's going to enlighten us regarding the awareness on theme IADVL, that is fight the topical steroid misuse. I'm inviting Dr. Mohan Lal.
It says I can't start my video. Host has disabled my video.
Sorry.
Thank you.
Yeah.
Good evening, all.
Yeah, carry on.
Yeah. Today my topic is misuse of topical steroids. I acknowledge our state, Telangana state IADVL for taking on this issue, like stopping misuse of topical steroids since a couple of years, and it is continuing. And my special thanks to Dr. Bhumesh is that he is continuing it, and I hope he will fight for it till the misuse gets stopped. So, and on this platform, we are all with you, Dr. Bhumesh sir. And so, from my now, I will share my practical experience of like where all these topical steroids are being misused, and by whom, at what level. Like when I think of like metropolitan cities, very rare, like couple of qualified persons are also like prescribing these doing this misuse of this topical steroids. Maybe because of like if I think from their point of view, like if I get into their shoe, maybe they are giving it to the stubborn or not, or more recurrent, or where the patient needs stresses on immediate result, or whatever cause, I don't know, but we are seeing that misuse is there. And the main part is being done with the beauty salons, in beauty salons. So, and beauty salons, they use it, and they like not having any knowledge of these steroids, and they are misusing this. And then when come to the like district headquarters type, there are physicians or pediatricians, they're like not sure of the diagnosis, and they start putting something as a thing. And at the same time, in district levels also, it has been misused by the beauticians again. Then at the level of town, it is like MBBS doctors are like only graduation doctor, like not postgraduate doctors. Many post-graduation doctors will not be there. So those MBBS doctors will write something like whatever it comes to them, or most of them. And at the same time, and then from there it goes to the village level. In village level, these ointments are like spread by like family and friends. So I have seen many students, youth students, they are like using steroids, like especially these, they say few names I can say, but this is not the point to say, point out the names. But like many companies have that, and they start using it for pimples. They use, for acne they use it for any, like any scars, and just for fakeness cream also they use it, youth students. And then when I ask them like who prescribed you, then they say that my friend has given it, or my sister is using, or my mother is using, so I have taken it from my mother and I am also using, or my neighbor suggested me that you apply this one, your face will glow. So like many people, like they're using these topical steroids as fairness cream. So in such a worst condition we are, that topical steroids have become fairness creams nowadays. So see how much it is going to impact people's health. And this is the time to fight against misuse of the topical steroids, and not only in Telangana state, but it should be like all over India, and even overseas also. This message should go. And as Bhumeshwar, wherever he goes with a placard like "Stop misusing of steroids." I really like that. Like hats off to Bhumeshwar, and so I hope, like it will be spread in any, like it will start like for any program we start with a national anthem, and as so we can it should become like that, like otherwise we cannot control, because already it is out of our hands. Already many companies are coming with steroid combinations, and it has spread into the root level, like village level of majority of the population. It has spread. So and our propaganda also should be from level side, like we are doing it at the metropolitan city level, but actually we are supposed to go into the roots of the nation, and to stop that. And we can, we can have placards or medical camps or whatever, we have to form a team committee for that. My suggestion, committee of national level, state level committee should be there to fight for the steroid misuse, which can sit and work out like how to work on this. They will plan, and they will work on that plan, how to spread this awareness to the village levels, like where we have the more population. Our majority of our Indian population is there. So we have to reach over them and educate them, and it is actually our social responsibility to save people's health and educate them about the consequences of. I have seen many patients, they have been using this steroids as a fairness cream since years together. And why you are, then when I ask why you are using since all these years, then what they say is, if I stop it, again my face is becoming dark. So I don't want my face to look bad, look dark. I want my face to look. Then we can't so that is the situation. And no one knows. At the same time, we can along with the stop misuse of steroid, we can tell them, we can empower them. We can tell them that start using sunscreens. Okay, because they go to fields and they are always open under the sky. So along with the misuse of along with this, we can add that also, instead of these steroids, you use sunscreens daytime, so that you will not get the skin tanning. So that is what one idea I am getting, and we can have some interaction with the RMP local practitioners. These practitioners associations, we can have interaction with them. Or they will be having their association. They will be having their association buildings. Also they have offices at taluk level, district level. They have their offices. I came to know that. So and they will be having their get-togethers and all. So we can, the committee which we form to look after this stop steroid misuse. Will that committee members will go to the district and taluk level of that actually in other way we can think, why should we go, we are the qualified persons, why should we go to their this thing, but we can go and it is awareness, like it is a social service what we are doing. So when we are going for social service, we shouldn't we shouldn't take into consideration that why should I go to the RMPs and talk to them at all. So those, we should keeping all those things aside. We should talk to the people and talk to the local practitioners and educate them. Just see, they are also human beings. Like they will also have some concerns over human and all. Because of their innocence, maybe they are using it. So we should tell them, see, these are the side effects of these topical steroids, and we request you to stop this misuse. And instead of that, you just can use some topical antibiotics or topical antifungals. So we can give them that counseling, and they will. They are also human being. I hope they will change their attitude of prescribing topical steroids to people. Like no one harms other person like willingly, because they don't know they are writing it, and from the national level, like as we have been discussing in our WhatsApp groups and all, at the national level, we must sit with the ministry or whoever is concerned with, like national health minister or pharma drug, like the director of the drug control and all. Our national body should sit and talk to, we have evidences from many big companies. We have evidences. We take these samples and talk to them and ask them to stop manufacturing these mixed combination of steroids. And I acknowledge Dr. Bhumi sir and TS Iadvl for taking up this this main burning unhealthy issue to in each and every session. So I am there with TS Iadvl to work on it. Thank you, one and all.
Yeah, thank you, Mohanlal. So this is a continuous process. Sai, can you share the slide? So this also we have prepared this slide for the faculty. So I am a RTSP star, that is a rational topical steroid prescriber. That I will not prescribe topical steroids for ringworm infections, pimples, and beauty or fairness creams. So this last faculty, they have participated. I request this faculty also to participate in this RTSP stars. So I request, I think, are all willing to participate?
I am willing.
Yeah, Abhishek ji. Abhishek.
Absolutely, sir. Absolutely.
And Sujay sir. And all those things, because this is a continuous process. By this we can you can put it as a DP or in your profile pic. So by that the people will be sensitized. It is a continuous process. We request you to sensitize each person, each faculty to sensitize another 10 people. Like that, the change should go. So that is so the initiation and awareness should come from all the levels, from the ground level to the higher authority. So on behalf of Iadvl Telangana, it is a small activities to contribute at the national level. Almost since 3 years, the national Iadvl also working with the team Iadvl to fight the topical steroid misuse, especially for healthy skin. So healthy skin awareness should be initiated. So even yesterday, Dr. PNR suggested. So we dermatologists, we should not prescribe combo creams. We should not prescribe creams for dermatophytic infections, for acne, for pimples. These all, at least let us sensitize by ourselves, and let us the society should sensitize, because the goal of Team IADVL is the members friendly IADVL and the subject friendly IADVL, and the same time society friendly IADVL. With this, we need your support and encouragement and the continuous process. Thank you. Thank you very much for accepting to take part as a rational topical steroid. The star is nothing but it's a mnemonic for scientific, trusted, appropriate, rational use of topical steroid. That is the meaning. Thank you very much. Over to Dr. Geeta.
Thank you, Dr. Mohanlal, for sharing your valid information, and thank you, Dr. Bhumesh, for keeping those star, which is resembling IADVL. You kept it as an emblem. Now we'll be proceeding towards our postgraduate quiz program. May I invite our quiz master, Dr. P. Padmaja, Professor, DVL Department, Gandhi Medical College, to conduct the postgraduate quiz program. Thank you.
Sai, quiz instructions.
Dr. P. Padmaja, ma'am.
Bharat.
Yeah, Madam Padmaja, Madam.
Good evening, everybody. These are the postgraduate quiz instructions. The 10 questions will be there. You have to answer all, and marks for the each question is 1 correct and 1 mark. And duration for the each question is 5 minutes.
The 10 questions is 5 minutes total.
Total 50 minutes.
5 minutes, Madam.
Huh?
The total duration of time is 5 minutes for 10 questions.
Okay. 5 minutes for total 10 questions.
Yeah.
5 toppers will be selected. Quizmaster decision is the final, and don't refresh or close the brochure. Let's go to the questions first. First question, please.
Question will be directly given to the PGs, ma'am. It will be directly displayed to them.
The questions will be go to the PGs, and the answer sheet will come to the quiz master, madam, after 5 minutes. Then you can read the question and answer. Sai, see the time.
Yes, sir. Yes, sir.
So once if you share, the time should be recorded.
The quiz has started, sir.
Okay. Sai, any questions for the two speakers? Any questions is there? After these 5 minutes, the quiz master will ask the questions to the
Sure, sir. Sure, sir.
Just post in this group.
Sure, sir.
Padma, you can also any questions to the speakers related to the leprosy. After this question answer session, the results will be the answer sheet and declaration. Then the vote of thanks.
Answers automatically displayed.
Okay. Once the questions 5 minutes, then any questions to the speakers, so then followed by all questions. Correct answer blue green lo vastadi automatic by ABCD lo. సాయి ఇప్పుడు మనం ఆన్లైన్ లో ఉన్నాం కదా
అవును సార్ 2 more minutes left, sir.
టైం కాగానే ఆటోమేటిక్గా స్టాప్ అయిపోతుంది కదా అది.
అయిపోతుంది సార్, అయిపోతుంది.
There are certain questions, 2 questions
Yeah.
I could see from the chat box.
మేడం కనపడుతుందిగా పద్మజ మేడం?
నాకేం రాలేదు.
చాట్ బాక్స్ కింద, చాట్ బాక్స్ లో చూడండి. జస్ట్ చాట్ మీద కొడితే మీకు క్వశ్చన్స్ కనపడతాయి. చాట్ బాక్స్ కనపడుతున్నాయి మేడం?
So quiz has been ended, sir.
Okay. Ma'am, Padma madam, questions. Query questions to the speakers. రెండు క్వశ్చన్స్ ఉన్నాయి మేడం, స్పీకర్స్ అడగండి.
The first question to the Dr. Sujay Sunit. Actually, there are some neurologists refer the case to the to rule out mononeuritis multiplex to lower leg to rule out Hansen's disease. There will be symptoms of tingling and numbness and loss of sensation without any hypopigmented patches. How to rule out Hansen's in those cases? Only the clinical examination or any other thing?
Sujay sir, unmute yourself.
I'm not sure if I got the question completely, but I think it would be clinical examination that includes nerve palpation and sensory testing, as well as voluntary muscle tests, all three, as well as looking for skin lesions, and in the absence of skin lesions, making sure we do a slit skin smear so that in case it turns out to be just an early lepromatous disease, then only a slit skin smear would detect that. The other thing would be doing an ultrasonography of nerves to look for thickening of the nerves. Do you think that's appropriate answer, Padmaja ma'am? I did not fully get the question.
No. Actually, there is no hypopigmented patch.
Okay.
And with the loss of sensation and tingling sensation of the lower limb.
Okay.
The patient goes to the neurologist. They're thinking of mononeuritis multiplex.
Okay.
They want to rule out Hansen's disease, and they are referring to the dermatologist.
Okay.
In that situation, how will we rule out by only clinical examination or any other test?
Yeah, I think
In those cases, I think there won't be any slit case examination is not useful.
no, but if it is early LL, ma'am, it's very important because there's a
no, sir. Actually, there is no hyperpigmented patches, and there
Yes.
is loss of sensation.
Yes. Okay,
If
fine.
you permit, besides sir's answer was absolutely comprehensive. I would say generally from the neurologist, what we get is mononeuritis multiplex. What we are worried about is vasculitis. And the clinical spectrum of presentation of vasculitis is entirely different from the slow inordinate progress of leprosy. The symptoms will be very slow to set in. One thing which I think sir would also agree is this is a right case to do if the capability is there in the department, or the is a nerve biopsy and rule out pure neuritic leprosy, because that is an appropriate differential in the presentation being presently being talked about. Rest all is absolutely bang on, as sir said. We do try our best to find a patch, do a nerve examination and a testing. These are standard guidelines, but the specific case that is being talked about, I think the symptomatology will help us rule out, and maybe cutaneous nerve biopsy would be of some help too.
Okay, sir. Actually, in lower leg, the cutaneous examination nerve biopsy means we can do only sural nerve.
Sural nerve, I agree. Absolutely.
But sural nerve should be enlarged. Otherwise, the patch, if it is not in the distribution of the sural nerve, then how will you do? Which nerve we can do? We can't do any other nerves now, sir.
No, you can't. I totally agree with you, ma'am. The only nerve that is biopsyable are defined to be either sural or the cutaneous branch of the radial. I fully agree with you. But sir has already pointed out, it would be a good idea to do an ultrasound. There is a question for PGs in if there is a sensation loss, there has to be a nerve involvement. That nerve involvement can be picked up by ultrasound. There are some early changes that can be picked up there. But if it is not in the distribution of the sural, unfortunately, it's appropriate that you not do a nerve biopsy. I agree with that.
Padmaja ma'am. Padmaja ma'am.
Sir, tell me.
I think also some studies have shown that even if the sural nerve appears to be uninvolved, that sometimes you can actually get success with the sural nerve biopsies. I myself have found it very surprising, ma'am. Many times I didn't expect that a sural nerve biopsy will yield a positive histology for leprosy, but you get a positive histology, ma'am. So it does not need to be something overlying the sural nerve or in the distribution of the sural nerve. Sometimes a totally unrelated patch on the same limb, you can get a few fascicles of the sural nerve showing histological changes. That's my experience, ma'am. So I think it's still worth doing that, or even the musculocutaneous nerve.
Okay, sir. But actually, in what way the ultrasound, after doing ultrasound, the report they'll give like some sensory deficit, some motor deficit like that only. How can we interpret with the hand sensor?
It's not so. I mean, ultrasound, you mainly look at cross-sectional area, ma'am, where you look for thickening of a nerve. So around 8 to 10 square millimeters is considered the normal cross-sectional area of a nerve. And when you find it's enlarged, that is one indication of leprosy involvement, possibly. And secondly, if there is a change in the echo texture of the nerve, when you look at it under a good resolution ultrasound, you see there is a change in the echo texture, in the way the hypoechogenicity of the nerve. So these are just suggestive that in the presence of sensory changes and the finding of an enlarged trunk or cutaneous nerve, then there is a likelihood it could be pure neural leprosy.
Okay. So actually, sural nerve without enlargement, it is useful, you think, by doing sural nerve biopsy without enlargement?
I don't know what Dr. Abhishek will say, ma'am, but I have found it quite useful, ma'am, that I didn't expect so many times that it will be involved, but sometimes I find it's involved, ma'am.
Some type of patients, like the neurologist refer to me to rule out Hansen's without a pigmented patch. That is a very difficult task for this.
Actually, neurologists should be excluding all the other neurological
Yes.
conditions and then sending it to us, ma'am.
Yes.
But they do the opposite, ma'am. They should exclude all the other neurological conditions and then send it to us and say, is it leprosy?
It's true.
Second question to Ajit sir.
Can I ask you one question, sir? Can I ask you one question related to this,
Is there after
if
that?
you permit?
One more question. Next question to Ajit sir. Which regimen we are following presently for the treating the Hansens?
Yeah, question from Dr. Ajit. That is question. Anyone can answer.
Abhishek, you want to take that question?
With your permission, sir.
Yes.
There is an interesting twist which WHO has introduced, and that is if you diagnose it as a paucibacillary disease or as a multibacillary disease, you end up giving what is called as the MDT-MB, adult or child, depending upon the age. You only change the duration, 6 months for PB and 12 months for MB. This is an interesting recent change. This is if we stick to the government guidelines.
Actually, previously also like that only, sir.
No,
it was PB,
true.
ma'am. PB has actually moved out. What we might be getting at the periphery would be the few end pieces. What is now in the program is it is MB only, and there is no PB pack as such.
Okay. You can ask.
Sir, is there any role of doing skin biopsy in the above case, sir? There is only pure neural involvement is there, no hypopigmented patch. But if you do skin biopsy, will get any information in the histopathology?
Yeah, I think Geeta, you can just know actually you, as a pathologist, if there is any
Yes, ma'am.
pigmentation, only loss of sensation in particular area we
no.
See, is
No,
there?
ma'am.
Yeah, I got a question, Geeta, ma'am.
Yes, sir.
My personal experience in pure neural, again,
Yes, sir.
I studied 300 pure neural cases, and
Yes, sir.
I found that 24 or 25% of them I found in the skin just either indeterminate leprosy or
Yes, sir.
just early BT leprosy.
Yes.
And very rarely I found 1 or 2 BL leprosy historically. That was in the deeper dermis, ma'am.
Yes.
And therefore, in the deeper dermis, there are few granulomas. In the deeper dermis, there is nerve involvement. Deeper dermis, there is M. leprae,
Yes.
but nothing in the mid and upper dermis.
Okay.
And that's why I think there are no skin lesions, visible skin lesions.
So
But
if you do deep biopsy up to subcutaneous level, you may
exactly,
get some.
we should include dermo-subcutaneous junction at
Yes,
least,
yes,
because
yes.
there are the nerves that tend to find nerve inflammation. Thanks
Yes.
for that question.
Thank you, sir.
Deepika
Thank
ma'am.
you, sir. Thank you very much.
Sai, answer it.
Yes, sir. Bharat.
Yeah, Padma ma'am.
Now, this is the first question. The causative organism of the leprosy in M. leprae, which is, the answer is gram-positive acid-fast mycobacterium. The second question. The route of entry of M. leprae into the body is through the skin alone.
No, I think it should be skin. It should be A, ma'am. That skin alone is wrong, ma'am.
Wrong, sir.
It should be skin and nasal mucosa.
Nasal mucosa.
I don't know that. I think the key was given wrong, ma'am.
Okay. Next. Third.
Pathogenesis of type 1 reaction is the uphill CMI.
Yes, ma'am.
Type 1 is to CMA. Yeah. Type 2 is immune mediated, complex antibodies. Okay.
Good question. The key histological component of type 1 reactions are the presence of inflammation and edema. And fifth question, the pathogenesis of type 2 or ENL reaction is gel and comb type 3 reaction. And sixth question, the sensory nerve conduction and warmth perception become abnormal in a large proportion of patients of leprosy. About what time prior to detection of sensory deficit using monofilaments? It's about three months prior. Next, seventh question. Immunologic reactions affect what percent of all leprosy patients? 30 to 50%. Next, eighth question. The WHO 2012 guidelines of for diagnosing leprosy recommend the following additional testing for the bacterial load: slit skin smear only. When performed correctly, ninth question, when performed correctly, the 5-year average sensitivity of the slit skin smear is around 35%. Then the last question, the most specific feature while doing ultrasound examination of peripheral nerves in leprosy is loss and destruction of the fascicular pattern. These are 10 questions and answers.
So, yeah, because that one question we are eliminating, only now out of 9 questions we are giving top 5.
Yes, sir. Yes, sir.
Yeah, go ahead.
So now I'm sharing the winners.
Neha Dhawan, Gandhi Medical College. Madam, చదవండి.
First 5. Neha Dhawan, Gandhi Medical College. And second one, Sneha Soma Reddy, Kakatiya Medical College, Warangal. Dr. Hinal Prajapati, GMERS Medical College, Ahmedabad. Dr. Soumya, Usmania Medical College. Dr. Salini, Government Medical College, Kannur. These are the top 5.
Yeah. Hearty congratulations, all of you. Yeah, so you will get the appreciation certificate as well as the gift. Thank you. Geeta.
Thank you, Padmaja Madam and Sujay sir and Abhishek sir for the question and answer sessions. You have clarified our doubts. And Padmaja Madam, thank you once again for conducting the quiz. Now we are going for vote of thanks by Dr. Janardhan. He's a professor, DVL Department, Bhaskara Medical College. Janardhan sir.
Am I audible, ma'am?
Yeah.
Yes, sir.
Am I audible?
Yeah. Perfect.
Am I audible?
Yeah, clear.
Honorable President, Honorable Secretary, our most valued invited guests and IADVL members, a very warm good evening to one and all. It gives an immense pleasure to deliver today's vote of thanks of today's Dermanar to all the delegates and PGs who participated on today's topic of leprosy. I thank eminent speakers Dr. Sujay Sunita sir and Dr. Abhishek Bharatwaj sir on behalf of TSIADVL for gracing this today's occasion and sharing a valuable information and experiences on the topics of etiopathogenesis and diagnosis, differential diagnosis in leprosy respectively. And I also thank Dr. Mohanlal sir for enlightening again on steroid misuse topic. I also take this opportunity to thank Dr. Geeta Madam for being today's Master of Ceremony and Dr. Padmaja Madam for conducting quiz for postgraduates. We thank all of you for participating in today's Dermanar and making it a grand success. We look forward for your future active participation in the forthcoming events. I finally propose a special thanks to Hetero Healthcare for their support for today's event. And I congratulate to all the postgraduate winners of today's quiz. Jai Hind and long live TSIADVL.
Thank you, sir.
Over to Bhumesh.
Yeah. Madam, ఒకసారి పద్మజ మేడం, గీత మేడం అన్మ్యూట్ చేసుకోండి ఒకసారి వన్ ఫైనల్ గ్రూప్.
Yes.
పద్మజ మేడం. Okay.
Thank you all.
Yeah, thank you, Janardhan bhai, Sujay sir.
Good night.
Mohanlal, Geeta.
Thank you and good night.
Geeta madam.
Thank you.
Yeah. వచ్చింది ఒక్క నిమిషం. అయ్యో. Okay, right. Thank you. Right.
Thank you, Dr. Bhumesh and everyone. Thank you so much.
Thank you, sir. Thank you.
Sir, kilo